So I think the role of an integrated care board is to try and create conditions for success for other partners to succeed for our patients. I think our role is to try and bring them together, to set clear outcomes, to support them where appropriate, help them to navigate challenges where we need to, but largely to empower partners and particularly professionals working in those organisations to work with our population to try and move care closer to home, to try and make the left shift now in terms of the government missions, ideally to get forward in terms of the type of digital support they would like to use as a collective. I do not think the integrated care board should be trying to prescribe everything that happens. The people that know how to deliver care are those on the front line, not those sitting in the integrated care board or the boardrooms of collective colleagues.
So we have two geographic care collaboratives in Coventry and Warwickshire, one for Coventry, one for Warwickshire. Our collaboratives are our health and care place partnerships. So we have around the table our acute trusts, our mental health trusts, primary care, public health, local authority, and importantly our voluntary sector and Health Watch and public health. And it's where all of those local leaders come together to make decisions and inform the commissioning of services, but collaboratively, and also how we deliver services in an integrated way rather than as individual services. So, and that's the key benefit really of collaboratives, is how all those partners come together and really look at how we join up our services to improve the benefits and outcomes for our patients.
A good example sitting within the care collaboratives was our approach around the community integrator contracts. And what we tried to do was to line up community services alongside our acute hospitals and really take some of the friction out of the flow, both in terms of admission avoidance and discharge, and to work with our colleagues on what they thought the most appropriate range of services and the method of delivery of those services would be for community providers. So the earliest examples you're seeing through the work in Coventry on one community integrated team, and in Warwickshire around community enablement, but they're just the start of trying to advocate for make a bigger left shift in terms of care, and to really own in the population health sense cohorts of patients in both Coventry and Warwickshire, working particularly with the local authority as our key partners here.
So we're going to see one of my patients now. I think this is the third time I've seen him. Initially he was discharged from hospital having been quite unwell for quite a length of time. Unfortunately, after coming home, did have a second fall and then was admitted into hospital again, and that all happened prior to me seeing him. I have set some carer goals for the patient, as well as things for him to work on that he wanted to do within his home environment. I've set him a home exercise program, which we will also go over today. I'll make sure that everything's okay, he's getting on okay with his carers, and basically that he's as happy and safe as he can be in his own environment.
I get around fine. Obviously, with the use of this implement, I'd try and venture around unaided, although I can use the walls and doors as support where necessary. Prior to being ill, every Thursday I would go on a 5 to 8 mile walk across muddy Warwickshire fields in the winter, year round, regardless of weather, with my walking pals. They still do it, I don't. One of my aims, long-term aims, with Adam's help, is to get back to doing that. I can assure you that 6 weeks in a hospital bed does nothing for a damaged knee. It made the situation significantly worse. So I'm very happy now to be, despite the fact that on some occasions it hurts a bit, I'm quite happy to be doing the exercises that Adam's taken me through.
Mum had a fall in her home and ended up in hospital for roughly 2 months. So she had some physio in the hospital and then needed further physio when she came home. They told us that we would have a service in the home, and the lady come out and done an assessment on Mum and explained to us that they would continue to do the service as long as she needed it, and it could go to the long-term care. Sophie, the lady that come to see Mum, built up a really good relationship with Mum, always pleased to see her, and she always done her best with Mum. She could do the exercises with her, she would do it. If not, if Mum was feeling a little bit sore that day and couldn't do very much, then she would just leave it. And then also she really went above and beyond on this one. Mum needed a new pressure cushion, and Sophie went above and beyond and ordered one for us, and it arrived the next day, which we thought was absolutely amazing. She also took you on a little walk down the path, didn't she, one day?
Yeah.
Out there?
Yeah.
And got you ready for going out so that you could go back to your bingo.
Yeah.
So what I'm really pleased about, I think, with the work both on Community Integrator and Care Collaborative has been how partners have come together and started to own the issue, own the problem, work out how we can get solutions in. I'm really proud actually of colleagues in the Integrated Care Board in terms of their approach. Letting go of some of these things is much harder than trying to keep control. We're not yet where we need to be. We've got a lot more work to do around left shift, but much of the focus of the community integrated contracts is around how we move to prevention, particularly secondary prevention initially, but hopefully in the future moving further upstream. There are still people stuck in our hospitals who should be cared for at home, further to go there both in Coventry and in Warwickshire. And over the course of this year we should see a greater rollout of our digital solutions, particularly around enhancing, expanding virtual ward capacities and remote monitoring.